We all know that surgery is the mainstay of treatment in localized pancreatic cancer. However, as an oncologist, we now understand that neoadjuvant and adjuvant therapy plays a very important role in the management of localized pancreatic cancer, not only for the downstaging, but also for reducing the risk of recurrence, as well as improving the survival outcomes. Our first speaker, Professor Jonathan Wesley, is going to speak about this very important topic. He has been one of my mentor while I was working in UK and helped me a lot when I was in early stages of my career. May I request Dr. P.N. Mohapatra sir to introduce our first speaker and start the session.
Thank you, Dr. Animes. And actually, Dr. Jonathan Wesley, it would have been best if he would have been come and with us, but he is a clinical oncologist, Western Park Hospital, Sheffield, UK. His areas of interest is thyroid cancer, neuroendocrine tumors, pancreatic biliary tumors, and molecular radiotherapy. He is currently the clinical director of the Sheffield Clinical Trial Center, Cancer Clinical Trial Center, Cancer Facility Lead for the Yorkshire and Humber Clinical Research Network, and a National Facility Lead of Radiotherapy and Imaging of the UK. Sir will be speaking in the research advance in neoadjuvant adjuvant treatment. Actually, pancreatic cancer, it's not like going for surgery in all patients. You have to discuss with the surgeon and the radiation oncologist. It is more of a trimodality treatment nowadays. So how we'll go for the trimodality treatment, and Dr. Jonathan will be speaking about that. Sir, please.
Rahul, can we have him on screen? Can we have Professor Worsley's slide on the screen, please?
Great, thank you. Can you hear me?
Yes, John.
Great.
Hear you.
Great. I'll make a start then. So thank you very much for your really kind introduction and invitation to speak at the meeting. I have to say, having just looked at the weather forecast in Kolkata, I rather wish I was with you in person. It's rather drab and cold and grey in Sheffield this morning. But anyway, it's a pleasure to be with you and thank you for the invitation. So if we can move to the next slide, please. So just to give a brief overview of what I'm hoping to cover in the next half an hour, we'll start by just having a little bit of a look at the background to the problem of treating pancreatic cancer. We'll then move on to look at the evidence behind adjuvant therapies, and then some emerging evidence regarding the benefits of neoadjuvant therapy, particularly for operable and borderline operable disease. We will think about locally advanced disease. I've said neoadjuvant therapy in inverted commas here, because to me, neoadjuvant therapy is a treatment that we give for disease that is operable, and clearly locally advanced disease isn't operable. So in the strictest sense, this is, I think, downstaging treatment rather than neoadjuvant therapy, but nonetheless, I think there's a role, and we'll briefly touch on that. We'll then look at the role of some of the more exciting new developments in the treatment of pancreatic cancer and how they may fit in, and then just draw us all together with a summary. Next slide, please. So I'm sure you're all very familiar with the problem that we're facing. So the International Agency for Research on Cancer reported in 2020 that there are nearly 500,000 new cases of pancreatic cancer globally. And as we know, sadly, the vast majority of those patients will die of their cancer. In the UK, pancreatic cancer is the 11th most common cancer by incidence, but it's the 5th most common cause of cancer death because it is so lethal. And sadly, it has the lowest survival rate of all the common cancers, with a 1-year survival rate of just 24% and a 5-year survival of well under 10%. And the graph here just shows the trend in 5-year survival of various different common cancers in the UK. You'll see over the last 50 years, for most cancers, there's been a steadily improving trend in survival. Pancreatic cancer is represented by the purple line at the bottom, which you'll see is disappointingly very flat and shows really very little progress. Next slide, please. So clearly the stage at diagnosis of the cancer is absolutely critical to the most appropriate treatment. And what we know is that unfortunately over half of patients with pancreatic cancer do present with metastatic disease and therefore are inevitably going to be incurable. And there are many efforts to try and address earlier diagnosis of pancreatic cancer, although for all the reasons we know that's very challenging. But even of the patients who have localized disease, only a very small minority, so around 8%, actually undergo surgical resection. And we know we can categorize patients with localized disease into three broad categories: those who are operable, those who are borderline operable, and those who are locally advanced. Can I have the next slide, please? So the degree of whether or not a tumor is resectable is decided really on the radiological appearances at initial staging, and particularly of the relation of the tumor to major vessels, particularly the superior mesenteric artery and vein and the portal vein. And if the tumor is too intimately involved with those vessels, sadly that renders the tumor inoperable. And the next slide, please. So there are various criteria defining resectability, but probably the most widely used are the NCCN guidelines from the States that I've put up here. And you'll see really the resectability status is decided on relation to arteries and veins locally. So resectable disease doesn't have any contact with the major arteries and has only minimal contact with the veins without any irregularity of the contour of the vein. Then this borderline resectable category that I think is very interesting, we'll be focusing on a bit later. So there may be contact with arteries and contact with the veins, but there are quite strict criteria about the degree of contact that can be had. And then the category of locally advanced disease, this is really where arteries and veins are pretty much encased by the tumor, and clearly there is no way that surgery is going to be successful. Next slide, please. Great. So starting by thinking about adjuvant therapy, so there have been a series of phase 3 randomized trials over the last 20 years or so that have demonstrated a definite survival advantage for post-operative systemic chemotherapy. There are challenges with this though. So most of these trials had in their inclusion criteria that the treatment had to start within 12 weeks of surgery. And we know, unfortunately, a significant proportion of patients are just not well enough to start systemic therapy within that time after major pancreatic surgery. The studies have also generally included both patients who had both R0 and R1 resection, so a proportion of these patients will have had microscopically involved margins, although generally they excluded patients with macroscopic residual disease. Next slide, please. So the first of these studies, and I should say the focus of my talk is going to be from a very European perspective, and particularly focusing on the work of the European Study Group for Pancreatic Cancer, who've been responsible for many of these trials. So the first of these trials, which was published in 2004, the SPAC1 trial, was really looking at two different approaches, and was a 2x2 factorial design. So the first question was, could adjuvant chemotherapy, so specifically with a combination of 5-FU and folinic acid. So this was the very old-fashioned Mayo regime that was used in colorectal cancer for many years, of bolus 5-FU daily for 5 days, 1 week out of every 4. The other intervention that was being tested was chemoradiotherapy, and it's slightly unusual and not a regime that we would use in this day and age, I don't think, but using 20 gray 10 fractions with concomitant 5-FU. So to cut to the chase, what this study found was that there was a significant survival improvement for chemotherapy. 5-year survival improved from 8 to 21%. So that was really very impressive and very significant. Interestingly, for the chemoradiotherapy, that actually showed a detrimental effect. So the patients who had chemoradiotherapy had worse outcomes compared with the patients that didn't have chemoradiotherapy. And this was really very significant for the role of chemoradiotherapy in pancreatic cancer in Europe, and really put paid to as using this treatment at all for many years. And that's changing now. But this study, I think, was very instrumental, really, in making us not use that treatment for many years. Next slide, please. Can we have the next slide? Great, thank you. So the next study in the series was the SPAC3 study, published in 2010. And this looked at the more modern drug gemcitabine, which by that stage had moved into routine practice for advanced disease in pancreatic cancer, and compared gemcitabine with the previous standard of 5-FU-folinic acid. So what the study found was that the survival curves actually were overlapping for the two groups, confirming a very similar sort of survival to the chemotherapy group from SPAC1. But what was notable was that the toxicities were rather different. So we know with 5-FU-folinic acid, there are really quite high rates of high-grade stomatitis and diarrhea that were really very unpleasant for patients. And that was much less of an issue with gemcitabine. The problem with gemcitabine, one of the problems particularly, was a higher rate of thrombocytopenia, but actually that very rarely caused symptomatic problems for patients. So in general, it was concluded that gemcitabine was better tolerated. And I think the result of this trial was that many centres moved to using gemcitabine as their standard in this situation. Next slide, please. So we then moved on to the SPAC4 trial, which was the first study to look at the role of combination chemotherapy in this setting. So comparing gemcitabine alone with a combination of gemcitabine and fluoropyrimidine. So this was a large study which showed that the combination treatment was actually superior. So the 5-year survival improved a little further from 16 months in the single agent group up to 28.8 months in the combination group. Next slide, please. Now, there was some interesting work that came out of this study looking at patterns of recurrence in pancreatic cancer. What we found in SPAC4 was that actually 90% of distant recurrences occur within 2 years of surgery. And in fact, half of liver metastases develop within a year. So those things suggest that this is disease that was probably there at the time of operation in terms of micrometastatic disease. Interestingly, there was no difference in the time to recurrence between either local or distant recurrences. And once you got a recurrence, there was no difference in post-recurrent survival, whether you had a local or distant recurrence. So all of this put together suggests very much that pancreatic cancer really is a systemic disease, and systemic therapy is really important. And we perhaps need to get on with that at an earlier stage in the treatment than we do at the moment. Next slide, please. So the final adjuvant study to report then, the most recent, was the FOLFIRINOX study. So this was a study run by the French group, published in 2018. So another large study looking at patients with very similar inclusion criteria, comparing the then standard of gemcitabine with modified FOLFIRINOX. Now, I think it's important to say it was inevitably a very selected group of patients, because only the fittest patients were going to be fit enough to cope with this very intensive combination regime. But the results are really impressive. The 3-year overall survival rate improved from 48 months with gemcitabine to 48% with gemcitabine to 63% with the combination regime. Now, I think just looking at the median survivals here indicates that this was a really very highly selected group, because we can see that the median survival of the gemcitabine group was much better than in the SPAC 3 or 4 studies. So I think this data needs to be, clearly there's an advantage for these selected patients, but this is not applicable to all of our patients with pancreatic cancer. Next slide, please. So clearly there are significant problems. Although there are advantages, there are problems to adjuvant therapy. As I've said before, many patients are not fit enough to receive treatment within 12 weeks of pancreatic surgery. We know probably only about 45% of all patients who've had pancreatic surgery get this treatment. And even the best results are really not great. So a 3-year survival rate of 63%, we could do better. And we know there's a very high R1 resection rate still, and that's known to be a very poor prognostic factor. Next slide, please. So neoadjuvant therapy, there are some clear advantages. There's an opportunity to get systemic therapy into the patient before they're debilitated by their surgery. We might earlier treat micrometastatic disease. There's a hope that we might reduce the R1 resection rate by shrinking disease before surgery. And we can assess the response to systemic therapy. There's something there that we can measure and see whether there's been a response. It may also allow better selection of patients for surgery. So we know some patients will progress through neoadjuvant treatment, but actually probably they're the patients with poor prognosis disease who are unlikely to benefit from surgery anyway. There are, however, challenges. Before embarking on neoadjuvant therapy, we need to get a histological diagnosis, and that can be challenging. There's concern about the potential to progress and become inoperable, although I think probably we might agree that those patients who progress through this treatment probably have very poor prognosis disease and weren't going to benefit from surgery anyway. And another concern is that actually compared with other solid tumours, the rates of response to systemic therapy in pancreatic cancer are not that great, and maybe this isn't a great group to use neoadjuvant therapy. So there are some concerns. Next slide, please. So I would like to share with you the results of the SPAC5 studies. This is the latest study to be published by the SPAC group, looking specifically at the role of neoadjuvant therapies in borderline operable cancers. And this was published recently in Lancet Gastroenterology. Next slide, please. So this is a multi-center study. It was really a feasibility trial run in 16 centers across the UK and Germany, looking at patients with borderline resectable pancreatic cancer by NCCN criteria that we looked at earlier. And the patients all had to have histologically or cytologically confirmed pancreatic cancer. They had to be good performance status. And there were 4 groups that patients were randomized to. So either immediate surgery, neoadjuvant gemcitabine with capecitabine, neoadjuvant modified FOLFIRINOX, or a neoadjuvant capecitabine-based chemotherapy radiotherapy regime. Next slide, please. So the patients had their treatment if they were having neoadjuvant treatment, and then had a restaging scan 4 to 6 weeks after treatment. If they hadn't progressed through that treatment, they then went on to surgical exploration within 2 weeks. Adjuvant chemotherapy was allowed post-operatively by investigator choice. I think it's important to say there was a lot of QA went into running this trial to make sure the results were reliable. So before going into the study, all the imaging was reviewed centrally to confirm that this was borderline operable disease. There was a lot of surgical QA, so there were surgical workshops run before the study set up, and then photographs were taken intraoperatively to confirm that the protocol was being followed. With the radiotherapy, there was quite strict QA run by the UK RTT QA group. So again, the radiotherapy plans were centrally reviewed before patients were treated. And there was also central review of the pathology, both the diagnostic biopsies and the resection specimens. Next slide, please. So just to give you an idea of how the trial panned out, so there were 478 patients screened for the study. Of those, only 158 actually consented to take part and were centrally reviewed. And of those, actually 68 were determined not to be borderline operable on review. So 90 patients proceeded to be randomized in the study. Next slide, please. So the primary outcome for the study, remembering that this was a feasibility study, the primary outcome was actually recruitment rate. And also looking at resection rate, seeing whether we could detect a difference between R0 and R1 resections. But there was also a series of really important secondary outcomes, including overall survival. Next slide, please. So the study ran over a 4-year period. As we said, of all the patients screened, actually only 90 were randomized. They were followed up for a median of a year. And there were 86 patients who had full data to be included in the full analysis set. So in terms of the number who underwent resection, so in the end, only about 60% of all the patients underwent resection. And there was no statistically significant difference between the 2 groups. And we know this fits with what we know about borderline resectable disease, that a proportion of these patients will be found to be unresectable when laparotomy. In terms of the R0 resection rate, again, interestingly, there was no significant difference between the 2 groups, the immediate surgery or the pooled neoadjuvant therapy group. So no significantly statistically significant difference identified there. Next slide, please. In terms of surgical complications, which was a bit of a concern for the neoadjuvant group, so we know surgical complications are relatively common with this major surgery, but actually there was no statistically significant difference in complication rates between the immediate surgery group or the pooled neoadjuvant therapy group. There were no deaths within 30 days of treatment at all. There were 5 deaths within 90 days of surgery, but actually all of these were patients who were unresectable at the time of surgery and almost certainly died of their disease rather than of surgical complications. Next slide, please. So the really interesting result from this study was looking at the overall survival rates for each of the groups. And if we look first of all at the lower graph here, which compares the overall survival, comparing the immediate surgery group, the darker line at the bottom, with the pooled neoadjuvant therapy group, the red line at the top, you can see there's a really significant difference in overall survival. So even though the study wasn't actually powered for overall survival, we were able to detect a statistically significant difference and a real advantage for giving neoadjuvant therapy to this group. Looking at the top graph, this splits out by a neoadjuvant therapy group. And although the numbers in each group are small and this is not statistically significant, we can see that the biggest advantage seemed to be for FOLFIRINOX, the next best advantage for gemcitabine, capecitabine, and although there was an advantage for neoadjuvant chemoradiotherapy, that seemed to have the smallest impact. Next slide, please. So the conclusions from the study are that neoadjuvant therapies are deliverable with acceptable toxicity and no increase in perioperative complications. There does seem to be a significant survival advantage to neoadjuvant therapy when compared with immediate surgery, but this isn't interestingly related to any improvement in the R0 resection rate. And again, this does support the concept that pancreatic cancer is a systemic disease that we need to get systemic therapy into early. The other interesting finding was that the grade 3 and grade 4 toxicity rates reported for the chemotherapy arms seem to be less than those reported in the adjuvant studies, suggesting that these treatments are better tolerated in patients before they have their surgery than afterwards. Next slide, please. So there are some other studies in this area, and just to highlight one of the run by a Dutch group, the PREOP-PANC-1 study. So this was a smaller but phase 3 study, including operable and borderline operable patients, so that both groups were included in this study. The neoadjuvant component was gemcitabine based, but included both gemcitabine and chemoradiotherapy, and the control arm was surgery with adjuvant gemcitabine. So the study did show a survival advantage for neoadjuvant therapy, but that was predominantly seen in the borderline operable disease group with a statistically significant hazard ratio, as you can see here. Next slide, please. So the Dutch group have actually undertaken a meta-analysis of all the randomized controlled trials that have been undertaken of neoadjuvant therapy. Oh, I've lost the slides. Can I have the slides back? So I can't see my slides anymore.
Kashish, Rahul, can you have the slides of Professor Watley?
Yes, sir.
Go back to the last slide where he was there. Yeah.
Great, thank you.
I think it was before that.
Can we just go back a few?
Before that.
Back a few more. Yeah, that's the one thing. No, that's the one. Great, thank you. So the meta-analysis included 7 trials had nearly 1,000 patients in total. They all involved gemcitabine-based chemotherapy with or without radiotherapy. So none of these studies included the more modern regime, the FOLFIRINOX. What the meta-analysis found was that overall neoadjuvant therapy did improve overall survival, but looking at the subgroup of patients with resectable disease, there was no statistically significant difference found, although there was a trend towards an improvement. But where the significant benefit seemed to lie was with borderline resectable disease, where there was a significant improvement in the hazard ratio. Next slide, please. So just a touch on locally advanced disease. These are the NCCN guidelines. And I think the evidence base is not great probably in this area. And you'll see for fit patients, there's a range of options recommended here. But some sort of induction treatment, in our practice, we would use chemotherapy to start with, but often then add chemoradiotherapy to that, or hypofractionated radiotherapy, SABR type treatments. Then there definitely is a role for those patients who don't have disease progression or have response to reconsider surgery. But we know realistically the proportion of patients with locally advanced disease who actually get as far as surgery is relatively small with the treatments that we have available to us at the moment. Next slide, please. So in terms of new developments, there are some exciting new directions in pancreatic cancer we're aware of. So looking at precision oncology and looking at the molecular genetics of cancers, we know there are a proportion of patients who do have targetable mutations, and perhaps one of those groups is those with the BRCA PALB2 mutations who might benefit from PARP inhibitors. Maybe there's a role for those treatments in that particular subgroup of patients in terms of neoadjuvant therapy. Clearly, there's a lot of interest in pancreatic SABR and the evolution of MR-Linacs, allowing much better targeted radiotherapy for pancreatic cancer. And although the role of radiotherapy has been a little bit disappointing in neoadjuvant therapies to date, maybe if we can target and give higher doses of radiotherapy to the pancreas, that may well have more of a role as we move forward. And also there's been investigation into novel radiosensitizers, which may improve the efficacy of radiotherapy. The UK trial that we've run has investigated the role of nelfinavir as a radiosensitizer. Disappointingly, that study was negative, but there may be other ways of enhancing the effect of radiotherapy to see better responses there. So I think many more avenues to explore in improving treatment for this group of patients. Next slide, please. So just to round up with some take-home messages, I think the data that I've shown suggests that pancreatic adenocarcinoma is a systemic disease and does require multimodality therapy. Serial studies have demonstrated survival advantage to adjuvant chemotherapy, but there is now, I think, very compelling evidence that neoadjuvant chemotherapy is advantageous, particularly for patients with borderline operable disease. The situation at the moment is less clear for those patients who have upfront operable disease. I think further investigation is required there. And more research is needed to determine how these new developments are going to be best incorporated into our treatment protocols to improve outcomes for our patients. So thank you very much again. I'm very happy to take any questions.
Thank you, Dr. Jonathan. It's excellent deliberation, such a crisp on such a devastating disease in that way, and a huge subject. We really thank you, sir, for learning so much from you. And I think absolutely the right talk is that it requires a multimodality therapy. And we open, Dr. Animesh, we open the discussion. I think someone should have a look at the chat box.
Yeah,
and,
I think,
and they see the questions there.
yeah, I think we've got 5 minutes for some questions. We'll open the chat box. Those who are participating online can type their question in the chat box, and those who are participating online can ask question as well. So can I ask Dr. Sujan to hand over the mic to Dr. Professor Ellen Viswas, sir? I think he has got a question.
I have a question regarding adjuvant therapy in operable pancreatic cancer. As you said, the results were definitely positive, but is there any subgroup analysis of R0 and R1 cases? Because the series of studies, all they included both groups, R0 and R1. So I am concerned, is it that because of a high incidence of, what is the incidence of R0 cases in those groups? So maybe because of high incidence of R0 cases, the results were more towards. So is there any subgroup analysis?
So yeah, so we know those patients with R1 resections definitely have a worse prognosis, but they do still benefit from. So there's still a survival advantage to them receiving the treatment. I guess arguably the treatment is probably palliative rather than strictly adjuvant in that group, because we know the outcomes are so poor. But there definitely is a survival advantage to having the treatment still, but it's not, those patients do worse than the patients who've had R0 resections.
Dr.
I mean, even
Allen,
the patients
you
with
want to
R0
pass some comment?
resections-
Dr. Anthony? Dr. Anthony,
Yes.
you want to ask, sir, please go
Yeah.
ahead.
I hope it's okay for the faculty to ask questions. So John, we in Leeds do exactly the same as Professor Wadsley do in Sheffield, but quite often after the radiotherapy, very quickly after the radiotherapy, when we do other scans, there seems to be local progression of the disease. And looking at the literature, it sometimes, to me, makes me feel, do we really understand fully what we're expecting to see after giving radiotherapy to a locally advanced pancreatic tumor? And could that be stopping us operating on patients who might otherwise benefit? And in addition, I don't know if you want to just mention the PET-PANC study, but a lot of the older studies, we didn't, as Professor Wadsley was saying, in terms of occult metastatic disease, do we need to be better at selecting patients before putting them through neoadjuvant treatment?
Yeah, thank you, Alan. I think really good points. And I think the whole problem of assessing patients after neoadjuvant therapy is a huge challenge that I don't think we do understand. In our MDT, as a rule, we say anybody who hasn't progressed should have a surgical exploration. And our surgeons say they can't tell until they get in. Really, it's very difficult to tell from the imaging what might be residual disease, what's just scarring. So we do take a fairly liberal view and give the benefit of the doubt, particularly to fit patients. The issue about staging, I absolutely agree. Better staging is important. We know PET has a role, and we do find lots of patients who have small volume liver metastases, for example, if we do PET, that we've perhaps not seen just on CT. But even when we've screened those patients out, I think there still is a high burden of micrometastatic disease, which I think is why the neoadjuvant approach is probably the way forward.
Yeah, Dr. Prosenjit Chatterjee. Yeah.
Yeah, thank you, Dr. Jonathan, for an excellent presentation. So to correlate to Dr. Anthony's question, I have two quick questions to you. Do you feel the current imaging modality, the CT scan and MRI, are adequate predictors for this pathological response? And number two, the question remains the same for borderline resectable subgroup, that can we understand if the patients have not rather progressed with neoadjuvant chemotherapy? Are they the group we can be taken up for surgery, or we wait that if there is still unresectable, these patients who have undergone neoadjuvant chemotherapy should be taken up for surgery? That's a surgery-based question, but what is your experience and take on that, sir?
So, as I said, I think the current imaging modalities that we have, CT and MRI, are, well, we don't understand enough about how to interpret them, and in terms of response to neoadjuvant therapy. So I think that's a very difficult question, and more research is needed there. I don't think MR necessarily has any particular advantage over CT, because what you're particularly interested in is obviously looking at the vascular anatomy, which a good contrast enhanced CT generally gives you the best information on. So no, I think it is very difficult. I don't think we really understand how to select which patients should go on to surgery. So as I say, our practice at the moment is to give patients the benefit of the doubt, because clearly surgery is really the only way at the moment those patients are going to be cured. Now, I guess as we move on with advances in radiotherapy and SABR and getting SABR up to higher doses, we may have an alternative to dealing with those difficult surgical cases. But at the moment, really, we know the only chance of cure really comes with surgery.
John, if you don't mind, I would like to ask a question to you. This is Animesh. So you mentioned about SABR. So my question is it still in clinical practice for whether it's localized or locally advanced pancreatic cancer? Is it in clinical practice that you use SABR, or is it as a part of trial? We know about SPARK trial was closed because of toxicity concern, but is it now in clinical practice? SABR?
So in the position in the UK is NHS England have just commissioned pancreatic SABR for patients with locally advanced disease. So we are rolling that out. Many centres in the UK are training to deliver that. So for locally advanced disease, it is moving into our standard practice. And I think there is evidence to justify that. In the neoadjuvant setting, I don't think there is yet evidence, and I'd say definitely need for more research and trials there. And I think one of the big challenges is what dose of SABRE we can get in with conventional techniques. So colleagues in Oxford, particularly using their MR-Linac, are running a trial looking at dose escalation on the MR-Linac, where I think that's much more feasible because you can give image-guided radiotherapy much more easily. So I think that's definitely an area to watch, and then that may then bring in a role in the neoadjuvant therapy. At the moment, at the place where we use that is in locally advanced disease.
Thanks a lot, John. Thank you for your valuable time and enlightening us with your knowledge and experience about neoadjuvant and adjuvant therapy in non-metastatic pancreatic cancer. I think we might have to close the session. If there is any burning question, we can just go with one more question. There are a few questions in the chat box. Yeah, there's one question from Dr. Shunita Prabhakar. Does all patients require adjuvant therapy? Those with no nodes or clear margin, do they need any adjuvant therapy? That's the question.
So the data from the SPAC group suggests that all subgroups benefit from treatment. So that I don't think we can identify a low risk group. Sadly, none of these patients are low risk. They are all at high risk of recurrence, and I think they all, those who are fit enough for treatment, I would recommend it. All should have adjuvant therapy.
Another question from Dr. Venkata Krishna Reddy. Would you suggest neoadjuvant RT in any group of pancreatic cancer, or SPAC5 has closed the coffin for RT?
I think for borderline operable disease, I think what SPAC5 strongly suggests is that this is a systemic disease and patients need the most effective systemic therapy as early as possible. And I think the reason radiotherapy has perhaps not been beneficial in that group is it perhaps compromises the systemic therapy that we can give. I think as radiotherapy techniques improve and we give better higher dose radiotherapy, there may be a role, particularly in inoperable disease, but I think that's very much an open question that needs further investigation.
Thank you, John. I think we'll close this session now.